Welcome. This is our second night in our discussions on precision medicine. I hope you were able to join us last night for the talk by Jeff Oxnard, and I hope that you'll be able to join us tomorrow night for a molecular cancer conference. If you haven't been able to do that, these talks will be available on demand later. Tonight, as we listen to our two great speakers, you can please feel free to post your questions, and we'll try to cover those at the end. I'm David Daniel. I'm a medical oncologist in Chattanooga, and I work at Tennessee Oncology. I think one of the biggest challenges we have in medicine in general, but particularly in medical oncology, is deciding when to adopt new technologies in deciding treatment. You can wow me with a story of why it should work, and I'm tempted to buy in. However, I think it's really key that as physicians, we understand exactly what we know and also what we don't yet know. So I'm glad we have two great speakers tonight. Both of these people I've known for years, and their judgments I trust without question. Scott Kopetz will go first. He's a professor in the Department of GI Medical Oncology at MD Anderson, after training at Hopkins and Duke and then at MD Anderson. His focus has been on colorectal cancer, and he helps lead the colorectal moonshot program at MD Anderson. Like I said, I've known Scott for 20 years, and I value his judgment and guidance. So I hope he'll help sort out my dilemma and how to embrace the technology in deciding when to treat early-stage colon cancer patients. After Scott finishes, we'll move to Melissa Johnson, and I'll introduce her further later. Scott, thanks so much for joining us tonight.
Oh, thanks so much, Davey, and to the group for the opportunity to present. It's a real delight to kind of share a perspective, and it's really an evolving story in colorectal cancer. So I'll be focusing, I think, as the group knows, in contrast to last night, this will be focused really on the kind of focused topic of minimal residual disease and in colorectal cancer. So some disclosures there. I'll be talking predominantly about colorectal cancer, just because this is an area that has really, where this technology has moved rapidly, and I think will, I'm sure, complement well some of the discussions we'll hear later from lung cancer and other tumor types. So I think you've heard about circulating tumor DNA last night, so I won't reiterate that, but I will say that what we're talking about, minimal residual disease detection, is really based on this concept that we now have the technology that is incredibly sensitive, and really, I think, acknowledging that we're now down to single molecule level detection in a vial of plasma, so that we can detect these variant allele fractions of 0.01%, which is obviously an incredible technology. And this enables now sensitivities that are now several logs improved from where we are now. And this is my slide that I kind of share with patients when and advocacy groups when we're trying to explain the concept of what we're able to accomplish now with this technology. And this is really one of these incremental leaps in sensitivity. And I kind of frame this as the same magnitude of benefit between our sensitivity in detecting cancer between a chest X-ray and a CT scan, right? Which was really revolutionary, and think about how much that has changed our management of cancer patients. But now we're really seeing this shift where we're now probably another at least 2 log improvement in our sensitivity using circulating tumor DNA. And so the question is, this is a tool, and as I'll share, it's a tool that has where the assay and the technology have rapidly come onto the scene. And now the question is, how do we use this information when we have this? Now, how do we actually improve outcomes for patients? So a terminology here of minimal residual disease. And so obviously heavily borrowing from hematologic malignancies and other settings. But in the concept of liquid biopsy, circulating tumor DNA, they'll be using this term, and I think the field has settled on this concept that when you can detect things with circulating tumor DNA with a very high specificity assay, and we'll talk a little bit about that, but where you don't see that information, you don't see disease on imaging, right? So this kind of threshold of detectable disease below the clinical detectable threshold. And this can obviously be used to identify these patients that may have residual disease despite surgery or despite surgery and adjuvant therapy. So I'll go through some of these. Now, this initial work, it actually came out of the Bert Vogelstein lab in colorectal cancer. The first paper really showing it in a patient cohort was a Nature Medicine paper back in 2008. So the technology's been around for a while, and they actually did this in resectable colorectal liver metastases. And what was seen here is these impressive curves where they could separate patients after resection who had undetectable ctDNA or those that something was detected. Now, the Vogelstein group went on to then apply this in a number of cohorts, including a cohort here in Australia. Jeannie T et al. Had reported this out and showing that these really remarkable curves. Now, I'll spend just a minute to comment on this because there's a few characteristics here that are important. One is these are assays that classically, and there's a lot of different assays out there, but this is a generalization, but that these are assays that tend to have very high specificity, meaning the positive predictive value. So when you see something, it tends to be real. And you can tell this because these curves all come down to zero. And I'll show you some additional ones here in a minute that I think will help show that. And then what you'll see is also a broad separation between these curves, right? And this is, you know, I've been doing adjuvant therapies and prognostications, as we all have, for years, right? And we would get excited about hazard ratios of 2, right? Separating, you know, high and low risk patients. And now we see hazard ratios of 13, 30, right? Where hazard ratios don't even mean as much in these settings because of the amazing degree of separation that we're seeing here. And so I think also important to look at, you know, how high that ctDNA negative bar goes. All right, so let's go through a few of them. I'm not going to belabor the assays themselves because I think the concepts are not necessarily what are the different flavors of ctDNA assays, but really kind of talking about the concepts and the general approaches that are being taken. So this is one of the assays that are now commercially available, and this is now the Garden Lunar assay. But this is not a tumor-informed, but where they've kind of incorporated some epigenetic components into the mutation panels, been able to filter out some of the false positives that come from CHIP and aging white cells. For example, and you can see very nice separation in this first cohort. And again, look at this curve going all the way down to 0. Now, it may be more than a year until some of these patients are recurrent, but these are patients stages 2, 3, and 4 after surgery and adjuvant therapy. So this a single time point being able to really separate things out well. This is the original cohort of Neterra. Neterra has an assay that is tumor informed, where meaning that the tumor is sequenced. And now you're looking for mutations that are only present in the plasma, only mutations that are also in the primary tumor. So it's a way to really weed out a lot of the false positives and increase the sensitivity of this. So very high positive predictive value and sensitivity, and there's now much larger cohorts that are being reported out with this. And then here's another one. This is now Roche Molecular, the Vineo platform. And that this is not a service as much as a kind of a kit and a platform that various labs can deploy. And you can see, again, very nice separation here in the curves. This is in stage 2 and then stage 3. And this is about where we are as a field, right? Sensitivity is about 50 to 60% for a single time point assay after surgical resection, right? Which meaning that there are some patients that still have residual disease. We just don't detect it with these single time points. But, you know, all of them have this very high positive predictive value, very high specificity. Now, in this, you get a sense of what the prevalence is. How often do you pick these up in the postoperative setting? So now, how are we using this? And I think these tests are available, and I know many of us, if you're like me, have people knocking on the doors, wanting to sales rep wanting you to order more of these tests and think about this. But I wanted to spend the rest of the time really thinking about, well, how are we studying this now as a field in colorectal cancer, and then more importantly, how can this actually accelerate things in the future? So the most obvious setting in a colorectal cancer is taking a stage 2 patients, maybe those that you wouldn't normally do chemotherapy, and then identifying that population that has residual disease that remains, and trying to understand how you deploy adjuvant therapy. Now, when this technology first came out, one of the first questions was, well, is it even too late, right? By the time you detect CTDNA, just like we say, when it shows up in the liver, we can't really cure it with chemotherapy alone when it's radiographically evident. Perhaps we're seeing it just below that threshold, but still in a range that we can't cure. And that was a really important question in the field. And I think the good news is that, yes, we actually look like when you can detect patients post-operatively and then give them adjuvant therapy, you can indeed kind of clear these. And that this is one of the first studies reporting. You can see small numbers here, and then additional studies really suggesting about the same amount. So about 30% of patients can clear their ctDNA and then be long-term disease free in many cases with use of adjuvant chemotherapy. So a lot of data being accumulated here, and I think we're going to have 10x the number of data points here in the next few months, with series that are going to be reported out at GI ASCO. But it does look like indeed this question of can we clear and potentially cure patients with adjuvant therapies? Yes. But we need a little more information. Now, here's one of the studies enrolling, and this is actually a study that designed with one of my junior colleagues, Van Morris, that's running through the NCI cooperative groups. So we really encourage, because one of the key messages here is that yes, these are exciting technologies, but we need to understand how to use them better. And so this is the Cobra study, stage 2 adjuvant, patients not a candidate or decided not to, I should say, where the decision was not to proceed with adjuvant therapy, can be randomized to test or not test. If test and the disease is seen in positive ctDNA, then going on to treatment. Otherwise, just continuing on observation then as well. Now, the other question here, back to our exemplar curves, are what do we do for stage 3? And clearly, here's a population that are recurring despite adjuvant therapy, and as almost all of them received, and then also some that had really good outcomes. And the question is, do we need as much therapy for some of these patients? So really better deploying these regimens. So there's a study that will be kicking off here in the US in the next few months. It's called the Circulate US. It's a companion to the Circulate Japan effort, part of the IDEA Circulate Consortium, an effort to really understand this nationwide. Again, a cooperative group study, NRG and SWOG led. It's T1 to 3 N1, so kind of early lower risk, stage 3. Pay all patients and undergo testing. I should say Cobra is being run with Guardant, the Circulate US with the Neterra assay, so we'll have answers across the board. Here, no ctDNA detected. Patients are actually being randomized to a standard chemotherapy, but we also recognize these are patients that have really good prognosis. And maybe these are not patients that all of them will need ctDNA. And given the ability to have serial ctDNA to detect these patients then go on to serial ctDNA testing. And if at any point they become positive, they go on to receive adjuvant. But if they remain no ctDNA detected, then we actually can avoid adjuvant in many of these patients, recognizing, of course, that many of these patients are cured with surgery alone. But if the patients are positive, either initially or later, then chemotherapy is appropriate. And asking a second question about whether escalation is possible. Can we do more intense chemotherapy here in the setting of FOLFOXIRI to try to intensify that? The Australians have a study that's actually already enrolling. randomized to be ctDNA informed or not. This is a very practical, and the Australian studies always are, practical study that says, just pick what you're going to do. Tell us what you're going to do. And if you get randomized to standard of care, you'll do that. If you're ctDNA informed, you'll take whatever you're doing if their patients are negative and de-escalate it. Go down one step in intensity. And if you're positive, then do the opposite, right? And try to escalate. So these are, several studies. There's about 18 studies for colorectal cancer adjuvant therapy across the globe right now that are asking this in various different iterations and with very related but different ctDNA assays. So we'll have lots of information on this here over the next few years. Now, I want to spend the last 5 minutes or so with a really critical thing. And I think this is nice, it's exciting, it can help our patients. But I think if we look back 10 years from now, it's not going to be how do we deploy FOLFOX better that is really why this is such a compelling and exciting area, but really about how do we go beyond optimizing adjuvant therapy? And can we actually get to a point where we're deploying novel therapies for these patients that would and have residual disease despite our surgery and our adjuvant FOLFOX? Now, there's a few characteristics that I see. I'm going to show you some of the data from the Neterra assay, although it looks very similar for many of these kind of high performance and current commercial assays. And one is that we have a lead time, right? Meaning that by the time that we detect things on ctDNA, there's about 8 months until things radiographically appear, right? So that there's a period of time that potentially we could intervene, like with the adjuvant therapies that we talked about, before things get so bulky and visible in disease. Now, it's not always, and you'll see in this showing the time to recurrence on the CT and the time to recurrence on ctDNA. And you can see in some, those are going up. So there are still some, again, sensitivity is good, but not great. Its specificity is the strength of these assays. You can see some that we're still missing, and there are some recurrences there. The other component is that in the absence of intervention, these ctDNA levels continue to go up, right? And there are a few cases that we've seen kind of them clear spontaneously, but those are pretty rare. And I think it's very common, the most common pattern looking at a lot of these large cohorts of patients is just this monolithic increase until the point of radiographic recurrence. So I think we can say in the absence of intervention, 99% of the time at least, ctDNA levels will continue to increase until radiographic relapse. Now, the exciting thing is that this is really enables some drug development in early stage tumors. And this is some commentary actually that Axel Grothe and I put together with Arvind Dasari and JCO last year. So I'd encourage, if anyone's interested, there's a very interesting kind of a proposal here that's in more detail about this concept. But the idea is that, obviously we're now at the point where we can do something really interesting, right? We can now start to do, phase 2 adjuvant studies. And I'll say adjuvant, quote unquote, right? These are really minimal residual disease studies. Now, when we think about adjuvant pre-ctDNA, really, there was no mechanism for proof of concept, right? If you had an idea about an adjuvant study as a pharma or otherwise, you had to get commitment from your leadership for 1,000 patients, right? Got to give me 1,000 patients and I'll answer this question about whether this agent is beneficial in adjuvant. So as a result, of course, there's no, de-risking this. Very few adjuvant studies were done. And usually only when we took agents that were working in metastatic disease and then tried to apply them in earlier stages. So the potential here is, of course, to use ctDNA as a surrogate marker. What happens to ctDNA with these novel therapies, and then perform these proof of concept studies through small phase 2s, looking for ctDNA clearance. So the idea, if you can clear ctDNA, really exciting opportunities to move forward. So the result, reduce risk and increase innovation. So this is kind of what it looks like. And I think I'll share briefly things that are ongoing in this space. CTDNA positive patients, you can do very small studies and look at clearance. And you also can do these phase 3 studies for registration where you have CTDNA positive randomizing to intervention or not and look at DFS. Remembering it's DFS is like 9 months. So you can do a phase 3 with 150 patients, right? These aren't 1,000 patient studies. So just a few examples. We know that role of TGF beta perhaps in these minimal residual disease for driving immune exclusion. So one of the first studies that I'm aware of was one that we ran at MD Anderson in the CTDNA positive setting. Patients were CTDNA positive, then went on to a PD-L1 TGF beta. The study didn't work, but I think it's a great go, no go, right? We could say didn't work. We don't need to pursue further. Other efforts ongoing, this is just acknowledging something being done in breast cancer, very similar, CTDNA positive, randomized to intervention or not. And then this is another one, and disclosure, this is a study that I'm leading where we're actually using the BioNTech mRNA technology, a personalized vaccine to take these patients and then randomize them to receive the personalized vaccine or not in the MRD setting. And then finally, gratuitous plug to say this is something we're so passionate about that we've actually built a whole program around this at MD Anderson. We have about a dozen studies coming in this setting. So it is a setting where if you've got patients that have the testing done and there's MRD positive, and the question is, what do you do? There are studies that we can then engage them on cellular therapies, IOs, ADCs, targeted therapies, other things as well. So there's a portfolio that's developing. Because one of the key questions is really is this a standard of care now, right? And I'd say maybe, but we're not quite there. A lot of key questions remain for this, right? And assay of suitability, of course. What's the appropriate intervention? I'm not sure that we should just be starting full fury on these patients just because they're CTDNA positive. There's no evidence that that actually works or improves survival, and a lot of reasons to say it probably doesn't. When do you do that? And then how do you communicate these results to patients, which is a major issue. So in conclusion, I'd say that, MRD applications are amazing opportunities, and they're really enabled by these high positive predictive values, right? And it allows us to then think creatively. Now, I think the terminology is important. These are not markers. These are not high risk of recurrence, right? It's not like our traditional adjuvant oncotype or something like that. We say these are high risk patients. No, this is disease. This is with this really high positive predictive value, we can say this is disease just as if there was something evident on the CT scan. So this is molecular persistence of disease. And we should really be thinking about these as stage 4 MRD, right? It's not, or metastatic MRD. It's not, these aren't the classic stage 2 patients. So I really think that CTDNA will change our approaches to how we think about adjuvant therapy. And I'd say absolutely ready to be engaged for drug development now, for deployment for novel therapies. But I think we really also have to think at the same time is this the right thing to be ordering for our patients walking in the door today? And I think there's a lot of questions that we have to ask our patients and ourselves to help make sure that we're ordering the right test for the right patient. So with that, thank you.
Thanks, Scott. That was great. We'll be back to you. We've already had a number of questions that we'll pose to you after the break. Melissa Johnson is one of my partners at Tennessee Oncology. She's a leader in an international leader in thoracic oncology and lung cancer care. She works through the Circulating Research Institution, as well as has leadership roles planning ASCO education in recent years. David Spiegel and Skip Burris were smart enough to recruit her away from Northwestern after she trained at MSK. And I feel really lucky that when I get stumped with a lung cancer question, I can text Melissa for phone a friend for help. Melissa's no Luddite. She embraces technology, but she also and she helps explore the use of cellular therapy in solid tumors at SCRI. But she also spends her days helping design and treat patients with these large phase 3 trials, trying to clearly outline questions. And so, Melissa, I trust your judgment in helping us understand lung cancer and use of MRD to help dictate care.
Thanks, Davey. Thanks for the opportunity, and thank you for letting me go second. Scott gave a great introduction to minimal residual disease and the concept of CTDNA, and we'll need both of those to launch into the lung cancer exploration of CTDNA monitoring. I'm going to start with just an introduction to plasma-based testing as we knew it in lung cancer that I'd argue started with the TracerRx study. So I'm going to tell you a little bit about that. And then I'm going to show you an example published to date where CTDNA monitoring was used in an adjuvant lung cancer study, a neoadjuvant lung cancer study, and a locally advanced non-small cell lung cancer study. You'll notice that what the three trials have in common is that they're super low numbers because we are still figuring out our standard of care. As Scott said, in colon cancer, it's the same is true in lung in early stage disease. And so there's more work to be done, as many questions to answer as have been answered. I'll summarize for you a couple of the clinical trials that we have available through Sarah Cannon, so the Tennessee Oncology partners can get access to those trials, as well as some other trials in progress, as we have an opportunity right now by enrolling patients in these trials to influence this field. So let's talk a little bit about the TracerRx study. So this was an analysis of non-small cell lung cancer early stage tumors. 100 patients were included, and 327 tumor chunks were analyzed. So these were all early stage patients who had had a resection of a stage 1 to a stage 3 cancer. And this is the first trial, first of all, to suggest that, or to prove that even early stage cancers were subject to intratumoral heterogeneity, and also that branched evolution, I'll explain what that means in a minute, was universal across tumors seen. And this wasn't a phenomenon that we only see in metastatic patients, but rather in early stage patients as well. So you see in the top illustration that the tumor was resected with curative intent in all 100 patients that were included. And then there were different regions that were analyzed for both mutations and copy number, chromosomal copy number analyses. And that enabled the scientists in this trial to put together a phylogeny, which was looking at both the clonal as well as the subclonal portions of the tumor. What do I mean by that? Well, the authors of this trial have coined the term clonal mutations or truncal mutations to mean all of those mutations that are present in every cell of the tumor. So they're present at the beginning and you can find them throughout. By contrast, then, subclonal or branched mutations occur in a subset of the tumor at some time after the genome of the tumor doubled in size. And so you can imagine that once there is variation in one part of the tumor versus another, you're going to see different mutations that exist. And that, keep in mind how important that is when down the line, when the patient has a metastatic cancer and we go in with a needle to sample the tumor's mutational landscape. We saw in this TracerRx that the mutational heterogeneity as well as the chromosomal heterogeneity varied with survival. The more heterogeneity you had, the lesser the more poor your recurrence-free survival was. There was some distinguishing components of adenocarcinoma and squamous carcinoma found in this trial as well. But I'll just point you to some landmarks of this trial. First of all, those clonal mutations, the authors noted that the tumor-specific clonal mutations were things like EGFR, BRAF, and MET. And so that makes sense to us now, because when we treat a patient with an EGFR TKI, we see rapid tumor response throughout the cancer. But once the genome doubling had occurred, and you see it happens earlier in adenocarcinoma, later in squamous carcinoma by a little bit, then patients' tumors started to develop subclonal mutations. And these were a myriad of other mutations. In fact, 75% of tumors had subclonal drivers in addition to the drivers that you think about as being clonal. So that included things like KRAS. That included things like STK11, ARD1A and B. So these are mutations that we're used to seeing, TP53, for example, Notch. These are mutations that we're used to seeing in next generation sequencing reports, but by and large, they happened in branches rather than the trunk. And then the last thing that's illustrated on this slide are these copy number events down here in green, and that referred to the chromosomal analysis that as the tumor continued to grow and divide, there were chunks of chromosomes, not just DNA, that begun to be divided and doubled. And so that contributed to recurrence of the cancer. The same group of investigators took those 100 tumors and also performed blinded profiling of postoperative plasma samples. And here we get to the ctDNA, because they were able to look at the plasma of these patients and correlate it with their eventual recurrence of their tumor disease burden. And so here you see just 9 examples, all just as different as they come, but I might refer you to this one, which was patient number 63. So first of all, let me orient you to their diagrams. So the sort of orange graph showed the blood sample that was taken pre-surgery, pre-resection. And then you see the ctDNA go way down. This patient post-operatively received chemotherapy, adjuvant chemotherapy, at 60 to 90 days post-op. And then you see there was no evidence of recurrence until here. You notice that the ctDNA began to climb, and the patient subsequently developed a paravertebral relapse. You see that between the primary, which is shown on the left, and the prevertebral relapse that was shown on the right, the truncal mutations in blue are still there. So those mutations were still common between those 2 sites of cancer. But while the nodes that are shown in green here in the primary were DNA that was present in the tumor at baseline that was resected, that was also in the bloodstream, by the way, at the time, shown by the green dots. They may be hard for you to see. Those were not present in the paravertebral relapse. This patient underwent radiation for that paravertebral relapse, and so now you see that the ctDNA started to go down until day 662. So that's 2+ years later, when the patient developed metastatic disease. That is diagrammed on this slide. So you can see here, and this patient actually consented to be part of a autopsy study called PEACE that followed TRACER-Rx. So this patient, at the time of his or her death, underwent an autopsy of the paravertebral mass, the lung primary, as well as a para-aortic lymph node. And here you start to see the significance of the clonal versus the subclonal mutations and how different each of the different tumor sites was. But also the phylogenetic tree at the top, you can see the clonal portion as well as the branches. All of which, by the way, is a little bit more present in the blood than it is in any particular lesion that is biopsied. So all of this to say, this a fascinating paper and body of work that continues on. But it was the first time that investigators started to use the plasma DNA, the patient's minimal residual disease, to both predict relapse in advance of imaging. But also, as we looked at those subclonal mutations, the copy numbers, could you predict, in this case, the right therapy at the time of relapse? Okay, so with that as sort of the background and the holy grail, because of course right now we don't stick 6 needles into our patients at diagnosis nor at the time of autopsy. Here's some other things that we've learned from CTDNA. Here's a study from a group that included investigators at Stanford as well as MD Anderson and Wash U, looking at a group of 40 patients with localized lung cancer. So these were stage 1, 2, and 3. And this study looked at CTDNA quantification that was taken at baseline prior to their definitive treatment, whether it was radiation, surgery, with or without chemotherapy. And then CTDNA was taken again within 4 months of the end of their treatment, and then again every 3 to 6 months until recurrence. So at a minimum, going back to Jeff Oxnard's talks last night, you see that there was less shedding for patients that had stage 1 cancers as compared to stage 2 and 3, where the concentration of CTDNA was higher. But even more importantly, you see that patients that had no CTDNA detected at any of the MRD landmark analysis within 4 months of treatment were much less likely to recur in the lines shown in black. In contrast, patients that developed positive CTDNA at that MRD landmark were much less likely to stay recurrence-free. They were much more likely to progress and pass away of their illness. And then furthermore, looking down at the bottom, this was also true at those surveillance assessment landmark, or not just the landmark analysis within 4 months, but every other analysis point. If you ever had CTDNA, you are much less likely to beat the cancer. You were much more likely to progress and die of your disease. A couple other things that came from this Chadhuri et al. Paper were, first of all, that, as Scott mentioned, that the CTDNA predicted for a group of patients that had worse survival, that had more events more quickly than those that were predicted by imaging. So of course, these patients in whom we predict we can use CTDNA earlier, that gives us an opportunity to act on them. These are patients with a recurrent lung cancer after resection. Can we add radiation? Can we add chemotherapy, immune therapy? The diagram on the right sort of reinforces this point. You see that the bar across the top showed that among 37 patients who were followed after resection, here you see the number of patients that had no evidence of disease at the MRD landmark analysis. And of those patients, you see that there were nine CTDNA samples that were positive at that point, and 100% of those patients ended up developing progressive disease down the line. Interestingly, there's a much bigger group where there was a lymph node that looked a little bigger, or a new nodule that looked like it might be growing, or some other equivocal finding, and the group was split almost 50-50, that in terms of patients whose CTDNA had turned positive. I can think of lots of examples where that's true. You probably can too in your own practices, where you see something and you think, oh my God, it's only 3 months post-op or post-adjuvant therapy. What am I going to do? I'm going to watch it. I'm going to scan again in 3 more months. And at that point, maybe you're more sure that there's progression. But what if you could do a ctDNA sample that would suggest actually we do need to do something now? One other circumstance that I think happens a lot where patients, I mean, maybe not as much anymore now that we're not doing as much radiation for N2 disease, but you know, once a patient has had radiation, of course, that obscures the ability to tell whether the part of the lung that's been radiated is harbors some recurrent disease over time. And so here again, I think ctDNA would be helpful. Let's go on to this study. This is a cute little study. It's a Chinese study, again, very small numbers, looking at perioperative changes in ctDNA. So patients, consecutive patients had CT or had plasma samples drawn immediately before surgery. And, you know, I don't know how many patients overall were tested, but there were 36 patients that were ctDNA positive at the time that they were being wheeled on a stretcher to the operating room. And that was the basis of the analysis. 225 plasma samples subsequently were drawn at 5 minutes, 30 minutes, and 2 hours post-op, 1 day, 3 days, and 1 month post-op. I want you to focus on the P1, 1 day post-op, P2, 3 days post-op, and P3, 1 month post-op, because that's where the differences were seen. So first of all, I'll tell you that part of the focus of this trial was to ask the question, is 1 day post-op too soon? Because of course, ctDNA can be shed at the time of the operation. And you can imagine why this would be. Your surgeon's in the chest, and they're cutting and they're dissecting, and all sorts of ctDNA is flying around in the circulation. It turned out that whether your ctDNA was positive or negative on that P1, your chances of recurrence were unchanged, to suggest that whether you have ctDNA that day or not may not be evidence of the minimal residual disease that Scott talked about, for example. In the trial calculated the half-life of ctDNA in the circulation to be 35 minutes, which I thought was super interesting as well. And it makes you wonder, what could you do to speed that up, or what sorts of circulations, metabolism, for example, would slow that down. Be that as it may, by the time patients got to their P2 time point, which was now 3 days post-op, there was a significant difference between those whose ctDNA had turned negative, that you see the recurrence-free survival in blue, versus those whose DNA was still positive in yellow. And it turns out that P3 and P2 were very similar. So between 1 day and 3 days post-op, all of the ctDNA that was being cleared from the perioperative inflammation, we'll call it, was over. And so by 3 days post-op, you could depend on that being predictive. They did a little analysis, subgroup analysis, looking at what of our classic predictors of response correlated with ctDNA being positive here. And sure enough, stage and lymph node status, the two things that we use to stage people right now, correlated with ctDNA. In my opinion, suggesting that this is a very good correlate. When it's positive, it suggests recurrence. So, those are two small studies. I wanted to bring up Checkmate 816 next. Of course, just reported at AACR in this year, earlier in the spring. And this trial, you'll remember, is a neoadjuvant study evaluating nivolumab and chemo versus chemo, 3 cycles followed by surgery, and with optional chemo and radiation out back. Of course, this was a positive study. The primary endpoint shown in the bottom left-hand corner of this slide, path CR rate, when patients received neoadjuvant nivolumab and chemotherapy versus chemo, showed a significant improvement in path CR rate at the time of resection for those patients that got nivolumab and chemotherapy versus chemotherapy alone. Now, just we can stop and stare at this result just for a minute, because heretofore, in the absence of a clinical trial, when your surgeon says to you, "Can you just give them a little something?" My surgeons say it to me a lot. "Can you just give them a little something to get this to be either a little easier or a little bit more manageable for me, or operable?" Wouldn't you want to do? And we always sort of wonder, is chemotherapy going to be enough? They don't want us to add radiation. Chemoradiation does work much better, but then that makes it a more difficult operation. So nivolumab and chemotherapy together seems to achieve more of what the surgeons are looking for, let alone the patients. There were a number of surgical outcomes that were also evaluated, by the way, and many of you will know that they all showed that the rate of more extensive surgeries was less. The patients were able to undergo lobectomy more commonly, bilobectomy or pneumonectomy much less frequently. But then another exploratory analysis in this trial was looking at CTDNA clearance. So this is one of the first times that we've had a prospective look at CTDNA clearance in a neoadjuvant trial. And not surprisingly, in this trial that was positive, the clearance of CTDNA was more common amongst patients that were treated in the experimental arm receiving nivolumab and chemotherapy versus chemotherapy alone. And that correlated with the primary endpoint, path CR rate. So wouldn't it be great if you could do nivo chemo, check a CTDNA, and know that it was cleared, and so you could go on to surgery with a clear conscience that an operation was the right thing for this patient, because of course there are times that we go on to operations and unfortunately the cancer is more extensive than we anticipated. One last study I wanted to tell you about. This is looking at CTDNA in the locally advanced setting. Here you see that this was a retrospective study. It included 37 patients who were treated prior to the FDA approval of durvalumab. So they didn't receive durva. They just got concurrent chemoradiation, and then another cohort of 28 patients that got chemoradiation followed by durvalumab. Both cohorts had pre-treatment CTDNA and then post-treatment CTDNA as well. Not surprisingly, if you focus on the middle here, I just looked at my watch and see that I'm running a little long on time. The patients that received checkpoint inhibitors, durvalumab, were more likely to go on to be recurrence-free, and patients that had CTDNA detected either before durvalumab or during durvalumab had worse survival. The most, I think, interesting part of this trial is this Kaplanmeier curve in the bottom left, showing those patients in whom CTDNA was not detected post-chemoradiation. And here you see that actually the patients that didn't get durvalumab did better. Now the numbers are really small here, so we don't have to quibble about whether there really is a difference, and this was 2 cohorts, not 1. But it does beg the question, as we treat all patients now with durvalumab, and some will have autoimmune mediated toxicities, if we were able to identify who those patients are that shouldn't get durvalumab, that would be beneficial for outcomes. I've raised some questions. There are a number of other questions that need to be answered yet. I wouldn't say that we've figured out exactly when to use this, but the themes are the same between the colorectal data and the lung cancer data. Can you use this to identify patients in whom adjuvant chemotherapy is not necessary, and so you can withhold drugs that may cause harm? Or can you use this to intensify therapy for those patients in whom traditional methods of adjuvant therapy are insufficient? For the sake of time, I think I'm going to skip only to, I had several examples of ongoing trials. Maybe I'll just highlight one that we have open at Sarah Cannon and within Tennessee Oncology, as well as our Florida sites. This Mermaid II looks at adjuvant CTDNA, and in patients in whom CTDNA is found post-operatively, those patients are treated with chemotherapy and then go on to be randomized to durvalumab or placebo. Now, patients have multiple opportunities during surveillance, if they flip positive, to then begin durvalumab. And while you might say to me, well, I can give everybody adjuvant atezolizumab now, I can say, well, you can't give adjuvant atezo to patients that are PD-L1 negative at the time of resection. And so that's one group of patients that I would consider treating on this trial. Moreover, patients that were enrolled to the adjuvant Empower 10 trial were 2 and 3. And so there are going to be patients that are left in that group as well. So in conclusion, I tried to argue that CTDNA holds a lot of promise in predicting relapse and recurrence after definitive treatment, but exactly how to apply this technology is unclear. So we need these trials evaluating CTDNA as a novel biomarker in all of the settings that I've reviewed tonight to determine which assay to use and in which setting. Thank you.
We're now going to go into a question and answer session, so please continue to send any questions you have through the chat, and we'll try to address those. So, Scott, I'll start off with colon cancer first. Are there any so we know it's a new technology. Are there patients you currently test, particularly if you're not considering them for a trial?
Yeah, it's a good question, and that's kind of this is the difficult situation we're in as a field, right? Where the technology's there. We can order it, but we don't exactly know how to use it to manage our patients yet, right? I'd say, so really, we've been trying to get all of our patients into trials. I think that, the most attractive areas in my mind are, the stage 3 patient that has, comorbidities, they don't want to do adjuvant, can that sometimes nudge them into getting treated where they wouldn't otherwise? I'm always in these rectal cancer patients that, maybe a watch and wait after a really good response. There's always that angst about, are we doing the right thing by not doing surgery? And, sometimes we've used it to kind of nudge a patient to surgery, even though the data for rectal cancer is honestly not that good yet, but will be coming. So, there's all these little boutique questions that we are thinking about. I think the real questions, like, do we need to give adjuvant therapy to all stage 3s? Should we be getting adjuvant therapy for stage 2s that are positive? I think those we really just have to wait for the results of the trials.
I can remember, Scott, when I was a fellow, seeing patients with Len salts, and we had a young woman with stage 2 colorectal cancer, and he said, I'd really love not to give her chemo. And I said, well, why? I was just thinking, like, why not help her be recurrence free? And he was like, well, because chemotherapy has side effects. It must have been early. It must have been early in my fellowship, but that's the crux of it.
But it is a good question, because oncotype and breast cancer, we're trying to identify patients who we can spare from chemotherapy. And in this setting, you're actually doing exactly the opposite at this point.
And I think in lung cancer, I know this wasn't directed at me, but in lung cancer, 5% at 5 years isn't great. So if we could identify those patients in whom it would help, and for everybody else do something different, that would be wonderful. Although I wouldn't say that I would know what test to deploy yet.
Yeah, I'd say, in the Circulate US, for example, the major huge stage 3, cooperative group study launching, that's half the study is how do you de-escalate stage 3s, right? So I think it will be a major part of that. So I think it really is about escalating in some patients and de-escalating in others. So
yeah. I want you to put your nickel down, Scott. Will that clearly answer the de-escalation question, or is that going to be so complex that we won't know?
Yeah, will it be like an idea 3 versus 6 months where it's, perhaps in the right setting and we're all, so we're trying to actually learn from IDEA. So this is the Circulate IDEA Consortium. So the idea is that the US does our study, Japan does their study, Germany does theirs. We merge the data because it's a non-inferiority questions, which are really hard to do, right? You got to have thousands of patients to answer it. So will Circulate US by itself answer it? Probably not. Will the international consortium, come together and, and we have pre-planned analyses that are being developed? I hope so. I hope we're going to be just like, and learn from Circulate or from IDEA.
Awesome. Hey, Melissa, so talking about de-escalation, do you think we could use something like this to learn about de-escalation of immunotherapy in the advanced setting?
Certainly. I think that we treat patients far too long right now. And the only reason that we don't is because no one is telling us that we can't, and the patients want to be treated. Immune therapy is not fulfurinax, and so you can keep it going. I got a lady 5 years out, used to be on a trial, and she just doesn't want to stop. We know that in melanoma, if you have a complete response by 6 months, then you can stop. And we know that in lung cancer, the same is true at 2 years, but it's probably between 1 year and 2, where you could use a negative CTDNA as your rationale for stopping. Look, patient, there's nothing left. This is a good reason to stop, and we can start up again if we need
to. Scott, so let's say we move to circulating tumor DNA serial testing. Does that mean CEAs are out the window, and should we all celebrate that?
Yeah. Well, I think it helps us inform the CEA a little better, right? So a little bit, helps with some of the angst that comes with the CEAs. I think the reality is, as oncologists, we're really good at adding new things on, but it's really hard to remove things from our practice. So I think CEA is going to be around forever. I really see them as kind of complementary, technologies that may be deployed. So yeah, I think so. And this corollary is, well, what about even, the hope is, can you get rid of CT scans, right? Can you be so confident that your lead time is sufficient with CTDNA that you don't even have to do a CT scan until something shows up on CTDNA? A little aspirational, but there's certainly people talking about that.
I can only imagine payers on that. They're pushing back on CT imaging. They're going to be pushing back on this if we're there. A little question about costs. And I agree. Melissa's saying if it improves outcomes.
I mean, if it tells you that your therapy is not working, and so the payer, doesn't have to pay for as much immunotherapy and gets to pay for more venetoclax instead, they might actually be up for it.
Yeah, and to be honest, there's so many. I mean, I think now, as opposed to biomarkers 5 years ago, there's so much focus on the value behind this. And I think, the fact that, MolDX and CMS is actually reimbursing this test now for colorectal cancer is because there's a real sense of value, and that kind of value argument was made successfully. So I think there is a bit of that is going to be part of what we're going to see. The classic academic studies, and we're going to see a lot of value-based studies that are going to move forward in this space.
Melissa, I didn't ask you, I asked Scott, would you send this in an adjuvant, newly resected patient at this point outside of a trial?
Not outside of a trial. I was remembering how we felt about Guardant 360 as just one example of a plasma-based test. About 6 years ago when I got to Sarah Cannon, and at that point we were a little skeptical and weren't quite sure where to use it. But by using it, we figured out that surveillance is a good application, that you can't do that with tissue. We figured out actually in frontline lung cancer how it can speed the time to applying the right therapy. So I suspect that we'll learn some things as well from the ability to order these tests. But right now I'm not using them in my practice, except lung 440.
Excellent. And Scott, if I lived in Texas and had just finished colon cancer adjuvant therapy, check it then. You have trials that we could send over patients over for.
Yep, absolutely. And we're deploying this now in everyone who's finished standard of care therapy, right? Where patients say, yes, I understand ahead of time that, this isn't about how I'm going to do, or we'll do something off protocol. It's like, if you're interested in, engaging in a clinical trial, if something's positive, then this is a good test for you. And a large proportion of our patients, of course, see the value of it and are doing it. But I think it really, what we've recognized is we got to make sure we have a what to do for every test that we order, right? And it sounds simple, but it's something we always struggle with as oncologists sometimes. So making sure that we can actually act on it. And so that's the hope, is to have and the goal that we've set for ourselves is to make sure there's always going to be a study for a patient getting a test.
I wanted to ask you about your Cobra trial. We have another trial that is very similar. And the problem with that, I wonder if you have problems with patients that are CTDNA positive, but get randomized to observation. Is that a difficult explanation?
Yeah, so what we do, very importantly, is we're not actually randomizing to the intervention, we're randomizing to the test, right? So we're basically saying, we're going to randomize you to just not get the test, or randomize you to the test, and if you're positive, we'll act on it, right? So there's no one who's positive that we then just sit on our hands, right? And don't do anything with. So that was our solution to get around that concern, because it is really hard to tell a patient you're positive, we're
going to watch.
You don't know what to do, but that's a
here's your anxiolytic.
Yeah, exactly. Right. You're positive, and right. So this is actually even more critical when we start to think about new drug development, because the patient advocacy community appropriately are saying, you know what, I don't know that that's fair to the patient, right? Test them for ctDNA and then tell them, like you said, Davey, right? Nothing we're going to do about it because you randomized an observation arm, right? Are we just invoking more, anxiety to the patient and not helping them? Which is hard because the FDA sees opportunities for registration, but they love the randomized study, right? To actually show improvement in DFS. So there's a little bit of tension at the moment on how do we design the registration studies for novel therapeutics, which is where we all want to go. But that idea that Melissa brought up of what do you do with a positive patient who's on observation is a tough one.
Kudos for your concept of the Intercept program. That's a really neat concept, and good luck with it.
Thank you.
Yeah. Is it so? When you showed us the graphs of the kind of the variability you see in the rise of is that even makes it even more complex, or do you tend to see time to radiological progression coincide regardless of this trajectory?
Yeah, so I mean, these are biologic assays like any, so there is some noise in the assay, and so you'll see over time that they'll kind of go up, but there's always a little noise as things go up and down. So you do need what you're looking for are large changes in ctDNA. I think the good thing is it's a really dynamic marker, right? I mean, as Melissa showed in a lot of the figures, when you see responses, it's a dramatic drop, even more so than we see radiographically in metastatic disease. So an active therapy is not going to give you a 10% change here or there, right? It's going to drop. And the hope is, and what we're doing is setting the threshold to say it's going to drop and it's got to disappear. Otherwise, we don't really, if you just go down some, that's not sufficient to get to a cure, right? If we're really interested in doing novel therapies to cure patients in this setting, we're looking for clearance. And so we're really setting a very high bar to look for complete clearance of ctDNA, which is, we would argue, necessary but not sufficient for an ultimate cure.
Mm-hmm.
Thanks so much. I could go on talking with you guys all night, but you've already given us a lot of time, and I really appreciate it. So everyone else, tomorrow night we have our molecular tumor board. We have Lee Schwartzberg leading that, but with medical oncologists all across the OneOncology network. Some of our friends from Foundation Medicine will help guide us on that. If you've never sat in on a molecular tumor board, they're really a lot of fun. You can learn a lot, and so encourage you to look at that at some point. So Scott Kopetz, Melissa Johnson, thanks so much for your time. Thank you.
Thanks for having me.
Thanks so much. Enjoyed it.